I, I think Deb and Lee covered most of the things that people think about in communication. And I just want to make a couple of remarks because I think it's, in a group like this, it's more important even to hear people's questions. Um, but let me say a couple things about communication. The first thing is it's a partnership. Communication is a two-way street, and this occurs in every relationship in your life. It's not just your medical relationships. And the same things that, that hold true to interpersonal relationships really are the same as occur with doctors and patients. Ours are structured. We deal with difficult subjects. People don't always want to hear what's happening. Physicians also have a lot of things going on. But it is about creating a partnership, even if it's only one visit. And it's about communication. The basics of communication are about listening. It's not just about what we can say. And let me be clear, in my view, listening is a two-way street. I'm not being a hard-nosed doctor, but we have to listen to our patients and listen to them in so many different ways. Listening is not just hearing the words. Listening is trying to understand who they are, understanding that people are different. Lee and Deborah talked about cultural context. To me, cultural context is not just whether you understand the language, which is obviously a barrier in communication, but it's when you meet somebody and talk to them, you kind of get a sense of who they are, where they're coming from, before you're even starting to talk. If it's a business deal, or if you're in the deli ordering a coffee, there's a number of unspokens that go on. And it's very important, while we don't want to overgeneralize people, there are things that happen in cultural contexts that we need to know. Certain society groups are much less willing to talk, to use a lot of the communication words that we use every day, saying cancer. When I went to medical school, I remember the conversations where the grand professor of medicine said, it really isn't a good thing to say, to tell somebody that they have cancer. And there are cultural groups now, people come to the office and say, don't tell mama, And so, well, this is kind of a difficult conversation. This occurs a lot of the time with children, and it's been very well studied. And it turns out that children, a 7-year-old, when you close the door, says, I know I have a cancer, I'm not sure, but no one will talk to me about it. There are situations where people come in and say, mom's very old, don't tell her the truth. There are cultures where language is different. There are cultures where you talk to the spouse and not often you talk to the male spouse and not the female spouse. So, that's part of a communication. The other part of communication, and this is something that we've taken very seriously in the Cancer Center, is the whole notion about putting yourself in someone else's shoes. In order to really be a good communicator, you have to know the person you're communicating with. Imagine that you're sitting in their shoes. So we've actually gone through a why don't we called it customer service, but it's not a good word. We tried to go through the last year. We get loads and loads of wonderful comments at the Clinical Cancer Center, but I also get the letters from people who said, here's why I'm upset. This person didn't do it. It took too long to get a phone call returned. It wasn't returned. I waited 3 hours in the doctor's office. This is a very small percentage, but if we don't focus on what we don't do well, we will never improve the way we need to. And part of it, when we got to even some outside help from outside the medical field, was really talking about putting yourself in the other person's shoes. So, when I hear a horror story about how, the doctor said the wrong thing, or didn't say something in a nice way, or in a sensitive way, the first thing, if you can just imagine when as a physician, when you're talking to someone else, how you might feel if you were sitting there. When we talk about literacy and using the right words, I think Deborah's example was very good. We assume too much about, in jargon, about what people understand. Axillary nose is not something that most people in the world understand. Axilla happens to be your armpit, and nodes happen to be lymph nodes, and probably most of you know that. But I am very careful in doing that and in teaching to work with the residents and the medical students as they're talking to people to try, not because we would talk down to somebody, but to try to use language that everybody understands. There are rules. We have an informed consent. By federal regulation, it has to be at the reading level of a sixth grader because we want to make sure that everybody can do it. But when we're talking to a patient, in Deborah's answer, she talked about the mediastinum. I don't know how many of you know what the mediastinum is. I certainly didn't know what the mediastinum when I went to medical school. It happens to be the space between the two lungs. And there's a whole lot of stuff there. Blood vessels, your esophagus, your windpipe. But if we don't use technical words and try to explain things clearly, we will do a better job. And you have to ask people if they understand what you're saying. And you can't take for granted what you know. You know, I hear somebody on the Hill talking about the committees and they got acronyms flowing out their ears. That's fine because that's what they do and they all get it. And when I talk to Dr. Axelrod, and we can have a quick conversation using code and stage and different things, we get it. But when I'm talking to you, I have to do the best I can do. And as a patient, and it's always difficult, people are intimidated by physicians. It just happens. You know, you got to stay, I don't get it. I don't understand that. When I'm in a lecture, I'm pretty good at putting out my hand and say, can you tell me that? Sometimes we don't want to show how little we know. I can guarantee you that 50% of the lawyers in the United States cannot accurately locate their liver in their body. It's a fact. I learned it as a kid because somebody bought me that wonderful plastic model. It was called the Invisible Man, and you got to put all the pieces together. But people don't know as much about their bodies as we assume that they do. And if we're going to educate them and talk, we have to do that. So enough on that. Let me just talk just about a couple of other things. One, it's our job to be teachers. We are teaching the patient about some information. So we have to teach like any teacher will do, build the information, keep the message simple. I try when I do a consultation, after I get all the information and I've summed it up in my head, to say to someone, here's what I'm going to tell you. It's kind of like the Mark Twain thing. Tell them what you're going to say, tell them, and then tell them what you said. Because you do want someone to come out of that consultation or that visit with a simple message. Not because there's a ton of detail. Sometimes someone comes in and they want to talk about 3 different regimens from 3 different consults and what do you think and the nuances, and they got 2 articles to show you. So at the end of the day, you have to come back with just cutting things down to the simplest terms so that they know exactly what you're saying. And sometimes you write it out and sometimes you draw a picture. And we don't always get it right. So one of the things at the end, and we get taught that regularly. Interesting, I saw it on a website. We had a mandatory malpractice course in the state, and it's a lot of it's all about communication. You want to lower malpractice, don't cut off the wrong leg, but actually the main things, most of it's about communication, and a very, very important part is at the end to say, as Deborah said, Dr. Axelrod, did you understand what I was saying? And the other, do you have any additional questions? I'll tell you one thing, looking at people really matters, and we are really getting challenged now because our medical center is going on an enterprise-wide computer system across the United States. Every doctor is going to be using computers, and I know, because I get some letters or complaints now and again, is, the doctor spent the whole time on their computer. People somehow have managed to get around the part about you writing something while you're talking to them. But a lot of people don't like when you're doing this thing, particularly if the computer's over here. And, we're kind of doing that and losing eye contact. So it's important in communication to do that. And I'm not sure what to do with the computer part of the problem because we do have to put information down. And we are now being increasingly required to put it down in a digital form and typing and writing. But you do have to take the time to stop and look at somebody and ask what it is they need. Now, let me say again, communication really is two-way. It's not always easy. The messages are not always easy. We're human. where our job is to do the best we can do. Sometimes patients are difficult. It's a real fact. When I'm a patient, I'm sure I'm difficult. But sometimes there are people who are just very difficult people. They come in with a point of view and they're really there to tell you what they want. And you have to learn to listen to each person differently. It's just like all the relationships in your life. It's about reading somebody. It's about getting them. It's about understanding who they are. And we know that in our lives and our other relationships, we don't get it right all the time. Some people are wonderful. They're great in a crowd. They can mix with everybody. Other people just don't read the signals well. And when they're really bad at it, we give names like Asperger's and things. But you try to read it. And as a patient, you also have to do that. It's not, this person isn't your enemy usually. It's somebody who's there to help you, and you have to work hard to communicate with them and to listen to what they're saying. I was talking to Lee before about the difficult patient, if you will, or when communication doesn't work well, it's usually when we misread. And when we misread, it's because I don't read right, because they don't read right. It is a failure in communication. And so all we can do is keep trying to improve that. When I was a fellow, and I'll just finish by telling you this, at the end of our residencies, we thought we knew everything, of course. We had a mandatory course at the National Cancer Institute where I was doing my training in medical oncology, where all of us had to meet once a month with a man who was a psychiatrist at Walter Reed. And it really was a course in communication. We met as a group. He was completely clear when we walked in the room he wasn't interested in any of our personal problems. He didn't want to tell us what bothered us. He wanted to talk about relationships between doctors and patients. And to this day, the people that I was in that group, except for me, have gone on to have enormously distinguished careers. They're some of the leaders in the field. They've been president of the national organizations, and people still talk about those sessions because he helped us to distill down, just at that point in your training, when you think you know everything and how to talk to everybody, and really to say, do you know how to listen to what people are saying? Do you know that the things that patients do in their own, anxiety to make you uneasy? It's as they're walking out the door and they say, so I'm going to be okay, doc, right? And you go, what do you say? Do you say, and especially if you know that they're maybe not, do you say yes? Do you ignore it? Turns out there is something in there. He really helped us to realize that if you let someone say that and leave the room, there was an unspoken contract that had just been written. And you didn't buy into it. So you sort of have to say, I'm going to do the best I can to help you. There are lots of tricks you can learn, and we spend a lot of time talking with our fellows and our residents, and we try to correct them. And then when we get wrong, even amongst ourselves, so part of my job is if a patient's not happy, I take it down to the doc. And I said, maybe you were having a bad day, maybe they're a difficult patient. The least you should know is that this person came out of that meeting not satisfied with the communication. It may well be that it's shooting the messenger. They didn't like to hear the diagnosis. But somehow we might have found a better way to do it. We might have put ourselves in their shoes. And when we do that, I think we have a better shot at communicating. But I think I should stop because I'll bet you that there's some questions here.